Hi, good morning, everyone. Welcome to this year's Endovascular Virtual Symposium. My name is Haroon Kamran, Endovascular Intervention Cardiologist. For my case today, I chose a case of critical limb ischemia from the last few weeks of my endovascular fellowship. This case highlights the importance of the choice of equipment and technique used for restoration of inline flow to the foot in patients with critical limb ischemia. Our patient is a 68-year-old gentleman with a past medical history of hypertension, diabetes, dyslipidemia and coronary artery disease, status post-intervention, and smoking. He presented to the office with left foot non-healing ulcers as shown in the picture, non-palpable monophasic Doppler positive pulses on examination. His medications included insulin, aspirin, amlodipine, metoprolol, lisinopril, atorvastatin, and cilostazol. As part of the non-invasive workup, he had an ankle brachial index done that showed an ABI of 0.67 on the left. A subsequent ultrasound showed mild disease of the SFA and occluded tibial vessels below the knee. He was subsequently sent for endovascular evaluation, possible intervention. So here is a left lower extremity runoff. As you can see, there's minimal disease of the SFA pop segment, but below the knee, there's at most one vessel runoff, mostly supplied by the peroneal collaterals. You can see them better in the subsequent DSA images. Here is a DSA at the level of trifurcation of the AT, PT, and peroneal arteries. There's a total occlusion of the anterior tibial and posterior tibial arteries, and rest of the circulation is via collaterals. Here is the image of the foot showing collateral supply and distal reconstitution of the posterior tibial artery. The decision was made to proceed with the endovascular intervention and attempt to restore flow into the posterior tibial artery. For this procedure, we used a simple wire catheter technique. The distal posterior tibial artery was identified, and using the wire catheter technique, as I mentioned earlier, we used multiple wire escalations from Fielder, Spartacore, V18, and finally Tuomo. Here, we use a knuckle loop technique using the same wire with the use of a support catheter. As you can see, we were able to subsequently cross the lesion successfully using this technique. Next, we put the distal wire past the posterior tibial artery, past the occlusion, Now, the important thing about this case was several attempts were made to cross the lesion with the atherectomy balloon devices, but we were unable to cross because of the residual stenosis. So here we use a coronary guide liner, 6 French, and using that we were subsequently able to cross with balloons and directional atherectomy devices. This was followed up by directional atherectomy using a Hawk EXL device, as you can see. This was followed up by a balloon angioplasty with a 2.0, 2.5, 2.10 nanocross tapered balloon. Here are the final images. As you can see, the posterior tibial artery fills briskly before the collateral supply and is able to provide excellent perfusion down to the foot. So in conclusion, critical limb ischemia is defined by the presence of rest pain or tissue loss over a period of 2 to 4 weeks, and this can be attributed to occlusive peripheral arterial disease. This in turn leads to subsequent limb loss, amputations, healthcare spending, and financial burden. Factors that favor endovascular intervention over surgical intervention include patient comorbidities such as congestive heart failure, coronary artery disease, COPD, CKD, age, and obesity. The ACC-AHA guidelines in 2017 gave a class 1 recommendation for endovascular intervention in patients with critical limb ischemia with non-healing wounds to establish inline flow down to the foot. Additionally, ACC, AHA, SCI, SIR, and SVM in 2018 deemed endovascular or surgical intervention as equally appropriate for the treatment of critical limb ischemia. So in conclusion, our case highlights the usefulness of different strategies and equipment selection for successful lesion crossing, device delivery, and destination therapies for restoration of inline flow to the foot in patients presenting with critical limb ischemia. This includes use of a simple wire catheter technique, wire escalation strategies, and use of, in this case, for example, coronary guide liner for successful delivery of equipment such as directional atherectomy and posterior tibial artery. Thank you so much.